Is it nice and cool there?
It's nice and cool in this physical room that has air conditioning.
No.
There you are, David. Excellent. Great.
We moved our offices. You wouldn't believe our new space.
It's great.
Awesome.
I'm excited for you.
I look like a shadow, don't I?
You do look
I look
a
like I'm a hostage being recorded somewhere.
A little, yeah.
Well, that may not work then.
I'd like to welcome everybody. This is the Milbank Memorial Fund monthly topical webinar. People are just dialing in now, and we'll get started a few moments after the hour. We have our speaker, David Kendrick, with us, who's going to be talking about the MyHealth Access Information Network. I'm very excited to be hearing about that today. And as a reminder, if you're using your computer to listen to the audio, please mute it. And if you're using a mobile phone, please turn that to mute as well. And that will eliminate some of the background noise. Thank you. We're going to be recording this webinar, so we'll be available on our website if you have colleagues who would have preferred to be able to listen to the webinar today but are unable to. So David, do you have an option to share your screen on the on the lower bar? Excellent. Great. Good morning or afternoon, everyone. This is Lisa Dulski-Watkins with the Milbank Memorial Fund. Welcome to the Multi-State Collaborative Monthly Informational Webinar. People are still just dialing in, so we're going to get started in a few minutes. And with us today is Dr. David Kendrick, who is with MyHealth Access in Oklahoma. He's going to be sharing some of the information about their fabulous information with data aggregation and analytics and reporting capacity. David, are you all set to get started? I think I'm going to turn it over to you in a moment.
All ready?
Okay, great. Once again, good morning or afternoon. This is Lisa Dulski-Watkins with the Milbank Memorial Fund Multi-State Collaborative. I'd like to welcome all of you to our monthly webinar. We have with us today Dr. David Kendrick from MyHealth Access in Oklahoma. He's going to be giving us a presentation about their journey from volume to value. I'm very excited to hear this, talking about their excellent progress and project with data aggregation, analytics, and reporting to the practices. As a reminder, please, when you join, make sure that your computer audio or your mobile phone is muted, so we can really minimize the noise that is sort of inevitable when people are on a call like this. Thanks very much, and I'm going to turn it over to David. David, are you all set now? I think everybody's on.
Oh, sorry. I had already started, but I was talking to mute.
Well, you got a little practice. That's great. Thank you.
Good. Sure.
Okay.
So So as I was saying to myself a moment ago, I would use my video, but it looks like I'm in a hostage situation if I show it to you. So because I've got a window behind me right now, so I'm going to go ahead and hide my video. I just want to confirm you're seeing my slides, Lisa.
Yes, we're seeing your slides. Thank you.
Okay, great. So some of these slides folks on this call may have seen before, but I'm going to give you the newest news today because what I find is that this story is always being updated at the rate of about 5 to 10% a month along the way as time passes. So this will be the newest news on this topic from my perspective. I also want to apologize because I went into the dentist for a cleaning today and I wound up with a buccal block, and so the left side of my face is completely numb right now. So if I sound like Bill Cosby in that dental skit, that's just normal for me right now. All right, so value-based payment models, we all know we're here to stay. That's why we're on this call. And the providers and communities are faced with multiple complex programs. So this in particular has been an emphasis of this administration and the folks at CMMI that I've been working with at least, which is to simplify the burden on providers, which I think is a good positive direction to be going in for sustainability and avoiding provider burnout for sure. And so one of the things that we've attempted to do with MyHealth is to provide a buffer layer that takes many tasks and some of the complexity off of the practices who are attempting to perform these value-based payment models. And of course, MIPS then is always in the background for those who are not in one of these models. You guys know this well, value is quality divided by cost. And so part of our job at MyHealth, beyond just moving the data from point A to point B so that when the patient is getting care, the full record is available for them, but it's also about trying to apply measurement to that data as it's moving. This, of course, is the key equation. Dan Duffy, one of our participants and our founding member of MyHealth, recently had an article in Health Affairs, and it showed very clearly that there are differences created by this complexity that we're adding to the system, so that large urban practices seem to be able to handle this complexity a lot better than smaller, independent, clinician-owned rural practices. And so that creates this sort of never-ending divide in America between urban and rural, and between large and small, and between complex and independent. And this is something that MyHealth is really trying to be a buffer for, because I think if you're sitting in a payer seat right now, you really are probably more concerned if health systems get bigger and bigger and bigger and bigger, and there are no independents in your communities. And if you're sitting on the provider side of the world, you have started to think of getting bigger and amalgamating with other providers as being almost a defensive mechanism, or the only way to survive, because there's so much administrative burden and overhead, and then your technology costs and so on layered on to an individually owned or independent practice. It's almost impossible to stay in business. So I just call that out to say one of the subtext of the MyHealth message is we really want to achieve better efficiency for everybody, not just what I will really focus on here, which is more valid and accurate approach to value assessment and measurement. So this is MyHealth. We have locations throughout the state of Oklahoma. About 2/3 of these are feeding us live data. The others are in some process of getting connected, or they're an organization type that doesn't actually have any digital data to contribute, like maybe the Health and Human Services Disability Assessment Program, for example. So these are the patients, though, that have data in MyHealth, and as you can see, about 75% of U.S. zip codes have somebody living in them that received care in Oklahoma in the last 5 years. So that's a pretty eye-opening picture to paint when you think about the fact that for me to go to the doctor when I'm on vacation or I'm away for work means I must really be sick. And so the data that we hold on these patients is relevant. Okay, so you may have seen this before, but we identify at this point 8 key critical success factors in these value-based payment models for payers and providers. And the first one I always talk about is multi-payer possible. This was our CPC Classic model. I won't dwell on it, except to say that it brought in a lot of new care management revenue to the community providers, and it went right down to the level we were most concerned about, which was primary care. And the multiple payers were working together very well, in addition to working with the practices. And for many practices, it was more than 90% of their covered lives. For all 4 years of the program, Oklahoma had savings, averaging about 4.6%, I think. And you can see here on the screen, it was driven heavily by this green line, which is all-cause admissions to the hospital. This is a Medicare Advantage plan that participates. They had a 14% savings overall annually. And then our results, I think it was the last year of the program, our results were 5.4% net. All the practices, of course, got a payout from that. And this is my best attempt at what the final numbers were for Oklahoma. You can see tildes everywhere. I didn't have the actual number, and I had to interpolate it based on the map. But you can see a pretty good chunk of payments for care management fees, plus the shared savings. All of this only after Medicare got their own money back for investment in the program and their savings. The commercial payers also had savings most of these years as well. Employers were excited about the program in our community. I think that's one of the great untapped resources here, is that we've not really engaged employers in many of our communities to be participants in this. And in Oklahoma, the employers that were excited also paid their own care management fees. So they were invested in the program. Now we're in CPC Plus with 181 practices, probably half what we hoped, but it just took a while to get them enrolled. So that's where we are now. And United is a new payer, and we're hoping to the mix, and we're hoping to have one more payer after the turn of the year. So then to get to the technology side of this, the first thing we felt was important was to have the correct scope of data. And by scope of data, we mean patient-centric. So if we think about claims data, it's a mile wide, but only an inch deep. If we think about the data any given practice has in their EHR, it might be a mile deep, but it's only an inch wide, because as we all know, real patients get care in multiple places. So the picture MyHealth tries to paint of care in Oklahoma looks like this. All the patients and their data across as many sources as possible, accumulated into one common chart. And then if we look at the claims data story, we also know that at least on the commercial side and from Medicaid, there's about a 20% a year churn from one plan to the next. So over a 4-year program, almost everybody's going to churn into a new commercial plan, which fragments the claims data as well. Speaking of fragmentation, we try to focus pretty rigorously on one of the challenges we have is convincing providers that the data in their EHR, both for taking care of people at the point of care and for evaluating quality and value and care gaps, is only a fragment of what most patients' data shows. And so this is one of the ways we do that. What you see on the screen is a histogram, shows the number of EHR data sources that each patient has. So if the patient's seen 3 clinics, then they're in the third column here because they've got data in 3 places. And what this shows is that across all of the people in Oklahoma, even if we don't have any of their clinics connected, 70% of attributed patients in MyHealth have records in 2 or more systems, okay? And that, of course, lines up pretty nicely with the study that my fam did while she was at Medicare that showed that the average primary care doctor has to coordinate care with 225 other doctors in 117 other organizations. All right, so see this blue line I put on the screen. That means that any given clinic visit on average across all of Oklahoma, and I shouldn't just say clinic, it means ER or inpatient, 30% of what is needed to be known is known in that one system, and 70% is outside of that system. So the average patient in the average clinical setting. That's a pretty big eye opener. Then we take a look at this, adding one chronic disease, and that number drops quickly to 13% is known. And the rest of it, what is that, 87, 86% is in other places. And then, of course, we always get the message given to us that, well, we use, big EMR vendor X that we paid $200 million for, or we use big EMR vendor Y that we paid $200 million for, and they tell us they're connected through their networks with their other installs of the EHR vendor, and so we don't need to look anywhere else for this outside data. Actually, this is our mapping of that based on the data feeds we have, and you can see the different EHR vendors here, Cerner, EMD, eClinicalWorks, Epic. We have more than 50 EHR vendors that we connect. I only picked the biggest ones and showed them here on the screen. And you can see that even among the largest, Cerner, Epic, they're running about 30 to 35% data that's only in Epic or only in Cerner or only in clinical work, and the rest of it is outside of them. And so if you're using only your EHR's connectivity, meaning Care Everywhere or Commonwealth or whatever, you're only getting a fraction of the data that we have in the Health Information Exchange. So I make that point because there are a lot more marketing dollars behind that part of healthcare than there are in the Health Information Exchanges. Most of us are nonprofit. In fact, all of us are nonprofit, and we're community governed and community based. And so we haven't done a great job of telling the story of data fragmentation. I'm trying to get there with pictures like this, but I think clearly you can see that it's way less than a coin toss as to whether I'll have the data on a patient I'm trying to take care of if I rely only on my EHR vendor's data. And so you can see there 31% on average across all EHR vendors known and 69% unknown. So this 70-30 split tends to play itself out in looking in the data in several ways. So I set that up to say the assessment of value is dependent on data, and we believe it's dependent on patient-centric data. That means the whole story for each patient. And what I've just taken you through is sort of the journey to get to an understanding of what we think of as a correct understanding of where all the data is coming from, where it needs to go to, and how we ensure that we're using the broadest picture of health for each patient when we calculate the quality measures, care gaps or alerts or whatever. So that brings up another concept here that we think is critically important to achieving value-based payment models success in this country, and that is that when there's a contract and there are parties on both sides of a contract, and there's measurement to be done, it's often not very productive to have one party or the other exclusively able to do that measurement. And in the case of historically pay-for-performance models, almost all the quality measures were calculated by the payers. And speaking now as a provider, often my experience would be that at the end of the year, I would get my report and it would show that I had failed on, say, breast cancer screening because I had not screened these 200 women that I look at the list and only recognize a few of because they were attributed to me in another way or they weren't visible to me or whatever. And so that wasn't a great feeling to feel helpless as a part of this supposedly even-handed contract. On the other hand, the payers are now in a situation where most of the time the providers are calculating the quality measures and presenting those to the payers, and the payers just have to trust it. So it's almost a self-attestation from the other direction. And so what we've achieved in Oklahoma is to get the payers and the providers both around the same table and to have them both contribute their data to a trusted third party where we do the measurement. And they're both on our board, so they tell us what to measure and how to measure it. But this third party does not care whether a practice succeeds or fails. I mean, obviously we want them to succeed, but we don't have any money in it and we don't have any performance scoring in it, so that we'll report what's true. And the payers, we also calculate the payer performance measures as well to give to the providers. So we feel like this creates a more even level playing field where everybody can trust that the results are what they are. And so we can do both. We get the claim that's created a situation where the payers want to send us the claims data and the providers want to send us the clinical data because that's the way they put their best foot forward for performance. And so we can do payer and provider specific metrics, assess the value, and the money can flow in response to the assessment of that value. What it's accomplished for us is both the creation of the Health Information Exchange and a voluntary all-payer claims database that's not necessarily funded by state tax revenue, but is funded by the payers themselves who use this tool to get the measurement done. So what's coming next in MyHealth is that we're now an accountable health community here in Oklahoma, which is another CMMI program that dovetails pretty nicely with CPC Plus, and we're working with social needs. And it turns out that the picture is very familiar when we look at social needs. Generally, they're funded by governments and philanthropy, and these are some social service agencies. And typically, if a patient has a social need, they've got more than one, so that there's fragmentation of the data across social needs agencies as well. And the Accountable Health Community Program is our opportunity to begin to tie social needs programs in with the healthcare delivery system, and we're in fact next week launching our accountable health community effort for a broad screening of the population. So that was all about the data itself, the substrate, getting the correct scope of information, because obviously, no matter how good your analytics are, how innovative your risk stratifications are, your predictions are, if the data coming into it is wrong, your answer will be wrong. All right, so the next thing is making use of this data at the point of care, the point of service, depending on the domain you're in. And so, of course, we provide a provider portal that shows a summary of the patient's history from all sources, and it can be explored and drilled into, and is available via web connection or single sign-on to the providers. Honestly, since CPC Classic began, what we've seen is an incredible rise in the use of this tool by care managers, who often find it useful to go here first before they contact the patient to make sure they're aware of the full picture of what's going on with the patient when they're going to try and close a gap with them. And we also see an interesting spike in utilization of this portal tool around measurement time, when people are looking for those mammograms, those colon cancer screenings that maybe weren't sent to them or that they are unaware of happening outside their clinics. We are about to launch an imaging exchange as well, because we know that's a high cost part of care, and we are just looking for another hospital system to do the pilot with us on, enough so that we have enough in it to cover the cost of the deployment. And this will allow those high cost images to be available through that same portal, so that no matter where the patient came from or is going to, the images can be seen and pulled down in their original form rather than just the reports, which we currently have. So again, back to this picture showing the fragmentation of data across the country, and I already described it within the state of Oklahoma. We also are a part of a project called the Patient-Centered Data Home, which if you don't know about, you should really learn more about. This is a project put together by the health information exchanges in this country, and we have 68 of us now. You can see most of us on this map. It's a little out of date. But what you see are that these health information exchanges have begun to connect with one another, so that when a patient gets care outside of their home region, the HIE in the region they went to will package up that data and ship it back to the patient's home region. That's why we call it the patient-centered data home, because it achieves essentially the fact that wherever you live is where your entire medical record will be. Even if you went away 2,000 or 3,000 miles somewhere else and got care, that data should come back to your patient-centered data home. The implications of that for the point of care are significant. For quality measurement and value assessment, I think it's of equal significance. So you can see here with the blue lines and dashed lines what's connected now. We've got 4 regions of the country connected, and we're getting, here in Oklahoma, we're getting, I don't know, several thousand messages a month from outside the state on patients who receive care, obviously mostly for us from Arkansas and Missouri and Texas, but we get a fair amount from Colorado and Indiana and Ohio and other places as well. So we think this is a very exciting development, and hopefully we'll be connecting all the rest of these yellow dots over the next couple of years. The next thing that we have found to be really challenging for practices is understanding who their patients are. And that's because obviously each payer, even though in CPC Plus they've agreed on the quality measures and they've agreed on the fact that they'll have the 2 tracks and that they'll be encouraging more risk-taking in the second track, they still do some things their own way. And attribution happens to be one of those, and risk stratification happens to be another one of those. And so in MyHealth, we recognize this scenario, which is that when a practice looks in their EHR, they can see the patient, they only are alerted to the patients they've actually seen in the last 12 months usually, or sometimes just going back to the beginning of the calendar year. But Blue Cross thinks these are the patients that the practice is taking care of, and another payer thinks these are the patients, and these are the patients from Medicaid's perspective, and these are the patients from Medicare's perspective. And this, as you can see, creates a situation where practices might have a lack of visibility into who half their patients are, because they're outside the scope of what their EHR might raise to their attention. And so we have algorithms for attribution in MyHealth, and that's how MyHealth users and participants get permission to get a whole batch report with 2,000 or 3,000 patients in it, right, is because we're able to attribute the patient to them. What you see on screen is a primary care attribution model. This is an older version of it. It's probably the most iterated on and improved thing we do in MyHealth. We just made an amendment last night to one of these in a committee meeting. And so this model is calculated every morning. We recalculate which patients go with which doctors and which doctors go with which practices, so that we can provide a report that looks like this to the practice, which shows this is a de-identified report, but it's one doctor's list. You see a list of patients here and their ages, and you can see different reasons these patients would be attributed to the doctor. So here you see a patient attributed by Blue Cross to the practice. The brown dot indicates the practice also claims the patient, meaning they sent us a message saying we take care of this person. And when we do frequency analysis, that is visit frequency analysis, we see that for all 4 time periods, this doctor is the most frequent visit this patient makes. And so if you look down this list, you see some interesting situations. For example, this patient here, 22 years old, they're attributed by Blue Cross, but they've never been seen by the practice or claimed by the practice, at least in the time window the practice could see, to tell us. But we also show that this practice is not the most frequent provider for this patient. And so when Blue Cross gets a quality measure on blood pressure, it's not going to be including this patient, right? And the same is true for another payer here, this happens to be community care, and so on down the list. So this report is really important to help practices understand who they're responsible, or I'll use the word accountable, for the care of, even though it may not be obvious to them in their EHR. The other item that we're still trying, the other nut we're really still trying to crack is how to help practices understand the very different risk stratification models. You've got HCCs for Medicare, which most people focus their time on, but folks will use Truven or 3M or a bunch of different models. And we're in the process of deploying a single risk stratification model that covers everything. So at least there's one method that is applied across all patient populations. All right, so the next thing that we try to do is make sure practices know not only who their patients are, but what care is being delivered to them outside of their practice. And so this is a tool we call Active Panel Monitoring. And Active Panel Monitoring basically lets me look at my patients for the last X hours. This is a report showing 24 hours in the past for a particular practice, and where their patients got care and what kind of care it was. Do they have a visit? Do they have an allergy documented, a new diagnosis, a vital sign documented, new labs, and so on? And so the practice can use this to really tailor their care management interventions, because they know who's got an urgent need for an intervention. And of course, it shows whether it was ER, inpatient, outpatient, whatever. Similar kind of report here. This is 30-day readmission monitoring, and this shows for a given practice. It can also be for a given hospital. All of their attributed patients that have been discharged in the last 30 days, and you see a calendar here across the top, shows what happened over those 30 days with I's and O's and E's to show whether this patient came to the emergency room or whatnot. And what I've shown here on screen is a patient that was discharged from a hospital and then showed up in the emergency room again a few days later without having an outpatient follow-up in between. That's an imminent readmission in most people's definition, and would certainly be something care managers would want to focus on. So now we're to really what I think is probably the main topic for this conversation, which is how do we assess value in MyHealth? And what you see here is a familiar picture now, hopefully, which is this fragmentation of data. And the way quality measurement happens, the clinical quality measurement happens anyway for any Medicare program, including CPC Plus in general, is that the measurement happens at the practice level. What that means is, let's just take hemoglobin A1C control, and we take some results that these patients have, because now with bedside A1Cs, everybody gets one everywhere they go. And so you see all these results for these 4 patients. If we just look at how each of these practices are going to report their performance, you can quickly see that across all these practices, they're each going to report a completely different set of answers on these 4 patients. And yet there are just 4 patients here. So what is a payer to do with these numbers? If I'm about to write a bunch of checks, or in the case of Medicare, what is the taxpayer to do with these answers? Because we're about to write a bunch of checks for quality performance, and we can see that there's really no way to judge which doctor did a good job from this picture, right? Furthermore, this creates a situation where the only way for a practice to perform well without interoperability of data is for them to repeat the test themselves until it's normal. So can you imagine if every abnormal measure lab test on here were followed up by enough lab tests in the same clinic to get them to normal? It would be a disaster from a cost perspective and a visit perspective. So take this picture now and rotate it 90 degrees to the right, and there it is on the screen again in this chart form. The other downside to this approach is I can't add up these numbers. There's no way to combine these numbers and get a community, population, zip code, or even payer-specific summary of what's going on with these patients' results, not to mention that the results themselves are wrong. So in MyHealth, what we do is we only calculate this number once for each patient because we recognize, remember the fragmentation chart, we know when patient A has data in 4 places, and we use the most recent hemoglobin A1C, regardless of which of those 4 places it came from. And so using that same data, this is the calculation of the performance on these 4 patients. And what you see here is 100% had appropriate testing, 50% are in control, and none of them are out of control. That's a much better result, and it's the result, what I like to say here is this is the result of the whole team's work, right? Teams in healthcare are difficult to define because patients vote with their feet, and they essentially build their own team as they vote with their feet. This approach to measurement that we've taken, that's person-centric, enables each person's own team to get its credit for its performance, right? The way we do measurement today devalues the team and requires that each of us as providers repeat the test ourselves, do all the work ourselves, and not allow the patient to go anywhere else for their care. So what we really want to know is we want to have the ability to roll these up to a population number because eventually this data would be useful for policy making, drug approval, direction of funding for new research. I mean, there are a lot of uses for this information beyond just the immediate use in a value-based payment model if we do it this way. So effectively what we've done in our approach is we've divorced the concept of attribution from the concept of the quality measure performance. And we say performance on a quality measure is a patient-centric thing. So in Oklahoma, we know all the patients in the numerator and all the patients in the denominator and all the patients excluded from this particular measure. Let's just take blood pressure control. And then we come back after we've calculated whether the patient's in the numerator or denominator, and we apply the attribution model I just talked to you about. And so if the program happens to be CPC Plus or some other primary care program, and we want to know how primary care providers are performing, then we apply the primary care attribution, and we find that provider number 1 is taking care of these people, and therefore provider number 1's performance is at 75% based on the count. Similarly, provider number 2's performance, because they're taking care of these other people, is at 67% on this particular measure. One of the nice things about this, though, is we're not limited to the primary care attribution model. What if we wanted to do a heart disease focused model and reward cardiologists for their performance? Now we can look at who's attributed to the specialist and therefore what the performance of that specialist is. And then finally, the model that got us into this approach, which was when payers approached us and said, you know, we don't really want to know the average performance in a clinic across all the patients. We want to know how are people doing taking care of our own patients so that we can tell the employers and the individuals who hire us to be their payer how we're performing based on their own lives rather than just on average. The other thing that this model creates by being able to report only my performance on Blue Cross patients, it creates a situation where I'm not disadvantaged as a doctor because I take a lot of complex or uninsured or Medicaid patients that might have other access to services and resources, right? I'm only accountable for the patients that have a similar set of access to care and resources per this payer's plans when I report my measures to them. So the payers in our community get their own blood pressure scores per clinic, per provider, based only on their own patients taken care of in those clinics. But you can see other uses for this approach. For example, public health reporting, knowing by zip code, knowing by community or neighborhood, we can get right down to the house actually on blood pressure control or any other quality measurement that we might report. And likewise, employers for the first time might be able to see what performance is on their own employees, not by name, of course, we would never share that, but to help employers understand the value of the healthcare products they're buying. So I'll just give a quick note on what it takes to get this done. We think of data that's substrate as the critical asset beyond only one other asset, which is trust is our primary asset in MyHealth. It gets people to share the data with us. But the second asset is the data itself, and it comes, in the course of time through several different sources, starting with the provider entering the data correctly, the EHR vendor handling it directly, mapping it or coding it directly, and then it transports to us, and you can see all the steps there that we go through to work on the data and make it usable for measurement. I won't dwell on this, but I'm happy to answer questions about it when we get to that. We also know that over time, the EHR vendors in the past have had a very difficult time in getting good, clean, standardized data out in the forms we needed. They're getting better at it, so this is kind of an old slide, but focus everywhere there's not a dot. Everywhere there's not a dot is data that's missing for quality measurement from these different EHR vendors. Again, old slide, looks better today, but it's been a journey to help these vendors and to help us understand their output better, so that we can show a particular organization their own data they're sending us and what variables might be missing from that data that are relevant to their quality measurement. When we report quality measures, we also try to calculate them in the central system. I will focus your attention hopefully on the data indicators table there in the middle, and what you see are a set of value sets. This is the variables for measurement, and you'll see a dot every time we have detected that a value set has been triggered. And then you'll see, of course, between 2014 and middle of 2015 is the measure window, and then you see a dot where each of those variables occurred, and if the user mouses over those, they can see the actual blood pressure in that measure or the actual A1C, whatever the measure is. And the reason we show this is we want to help practices and payers understand just how many clinical sources of information it might take to get a patient in the numerator. This is a blood pressure control measure, and you can see 6 different sources here contributed meaningfully to this patient being in the numerator in blood pressure control. Similarly, we know that quality measures are complex, so we've taken the quality measures and we break them down into their steps so that the user can mouse over each of these circles and be told what was that decision step in the measure and how many patients landed in it, and then if they click on the circle, they can see which patients are in that dot, so that if they've got an unusual amount of patients failing at a certain step, they can actually focus on not just our 30-day readmission rates are high, but our 30-day readmission rates are high because what? And they know what next step to take. When we present quality measures, we try to enable the practices to see them not only according to, say, one payer's benchmark, but we allow them to choose the background benchmarks. Here you see the MIPS registry benchmarks that we've shown on these particular measures. If I go to the next slide, you can see then another innovation we put on here so that the practice can choose the percentile they want to get to. And when they click on that bar, it shows them not only what their current performance is, but what performance they would need to get to get to that new percentile, and a number needed to treat. That is the number of additional patients that they would need to treat in order to hit that target over the course of the year. And of course, they can look at this when they want to. And then finally, there's a link at the bottom there of that pop-up that shows that they can go directly to a list of the patients. And when they click that, now they're shown a list, the identified list of the people who have the care gaps that would get them to the next list, so they can focus that and really target the right folks to improve their performance. And then we also can show their trajectory. How are they progressing towards scoring well on the quality measure? So you can see here, we've just basically done a curve fit, a linear curve fit to their performance, and it shows them at the end of the year, if they stay as they're performing now, they will hit a performance of 48% on this measure. So they're going to have to step it up to make their breast cancer screening score hit the target they want. I will just make one sidebar comment about benchmarks in the MIPS program. And there are actually 3 sets of benchmarks, depending whether you report from your EHR, which is the orange, or from the claims data, which is blue, or from a registry, which is what MyHealth is, which is the green. So this is an advantage of being, it's called a qualified clinical data repository, or registry, sorry. And MyHealth has won several other HIEs or QCDRs. And that not only gets you the ability to use lots of data and combine it for quality measurement, but also, as you can see, gives me a more favorable target. This is A1C. Poor control at the golf measure, so lower is higher performance. You can see that there's about a 10 percentile point difference between the performance required to hit the 90th percentile on A1C control here for those using registry. Similarly, this is LDL cholesterol control, and you can see there's quite a broad difference between what the EHR report would require and what MyHealth has to hit to get the practice to 90th percentile. Not all measures work the same way. High blood pressure is somewhere in the middle in their benchmarks. Breast cancer screening is the opposite. The easiest way to report is from that is EHR. So there's a bit of strategy that practices can apply here. The next thing we think is critically important is that the practices understand cost and utilization. And in TPC Classic, we were able to demonstrate to practices how their costs compare to other practices. This is a change in ER visits and admissions very early on in the CPC Classic program. This is the cost of care by practice for one period in time compared with the same period in time a year before. Everything in red cost higher. The practice costs were more than they were in the last year, and then they're ranked from high to low so they can see how they perform compared to one another. And then this is our actual new modern version of our data aggregator report that we offer practices in Oklahoma, showing multiple payers and their performance across multiple payers and compared to their peers in these box and whisker plots with this familiar measure logic view diagram as well. So I will stop there and take any questions you guys might have or go back and review, but thank you for your time today.
David, thank you so much. I'd like to open up the discussion. If anybody has questions they'd like to ask David, you can put them in the chat if you'd prefer that I ask them for you, but all the lines are unmuted centrally, so please ask away.
David, this is Dick Schonk in Cincinnati, and every time I see this presentation, it gets better every time. So congratulations, you're really hitting it out of the park. One thing that I've been struggling with is when we put this data together is and I don't know if you've had any conversations with your payers, and I understand they only want to pay for the improvements they see in their population. But I also think that from the provider perspective, at least from the standpoint of network development, if I'm a payer, I want a practice in that I know is doing good work across all their payers. And I may be able to determine that because I have more data if I look at their aggregate results as opposed to the results of my own population. Have you had any conversations with the payers to say, hey, we might be willing to at least pay a part of our incentive for aggregate performance versus just performance in our own population?
You know, it's a great point, Dick. We haven't had that conversation yet. We're really still ironing out the science of doing it this way. Mm-hmm. But you know, the numbers they get now through the CPC Plus reporting when practices report to Medicare are those numbers. Right. So I do know that they use them as a second reference point. It's interesting. You reminded me of a story I didn't get to tell during this, but one of the powerful things about having this trusted third party is when this approach to measurement we're doing doesn't work, and for the first couple of years it's very hard because the data coming out of the EHRs was not complete enough, and we were asked to calculate 13 measures, and sadly our feeling was that only 3 of those measures were reliable in the first couple of years because of, you know, we weren't getting diabetic eye exam data from practices, but we were getting A1Cs and blood pressures and what was the other one? Mammograms, I think, pretty reliably. And so when we calculated that, we took that to the payers and said, hey, we think you can only count on 3 of these measures done in this method. They agreed with us. But what do you think they would have done if an individual practice had come to them with that request? It never would have flown, right? Because hey, your contract says you're going to do it, you just fail. So we think that that's one of the positive aspects of this trusted third party approach, is that we can get to reasonable without, completely upending either the practice or the payer in any given year, that they can actually have a negotiated reasonable stance. So no, we haven't directly tackled that, but I know the payers still use the practice-wide reports they get from the CPC reporting.
Well, you make a good point in the fact that the payers aren't uniform in what they cover and access, authorization for things. So it may not always be appropriate, and I certainly wouldn't think 100% incentive-based aggregate results, because those things do vary across payers, and so I think you always have to make some allowance for that. It's a good point.
Yep, absolutely. I mean, I'm sort of an extreme case there, because I teach in an academic medical center where all but 5 of my patients are uninsured in my clinic.
Right.
And those 5 have commercial insurance. And I can tell you, when I'm begging and borrowing medications to manage blood pressure and diabetes for 98% of my people, my performance is not going to be what it is on my mostly commercially focused peers.
Yep. Yep.
Hi, does anyone else have a question for David? David, this is Lisa. I wanted to ask a question with something we talked about a couple months ago in terms of how the practices are really faring in using this incredibly complex information. It's potentially so useful for them, but also can be somewhat daunting, and what your thoughts are in terms of what's required for them to really be able to effectively take advantage of what the opportunities are.
Well, to be honest, it's a slog, because a big percent of the practices are in large health systems, and for the sake of survival there, they usually toe the line and use the internal tools. And there's a lot of pressure from the major EHR vendors, understandably, because it's their business, to use their internal population health management tools, quality measure calculation tools, and so on, even though hopefully I convinced you that they're only looking at a fragment of the data when they're doing that. So we have to sort of swim upstream against the current of those forces to get people convinced to use this data, which makes it a little easier to convince small practices than big health systems. But since most of the patients are being taken care of here in big health systems, that makes it challenging. We did have a big health system on man's greatest EHR platform that insisted that our numbers were all wrong in our calculation of quality. And we took them on a 3-month journey where we basically said, give us 200 patients, any 200 patients, and we will line by line, visit by visit, go through the data as you send it to us and show how the calculation works. And we were at 99.5% in total agreement on what the answer should be, which I think is pretty good for quality measurement in this space. And we could point to all the evidence and facts that were there. So I think that's the part of the challenge is getting folks to recognize that this person-centric approach to measurement is actually perhaps one of the only valid ways to do this kind of work, but at least is as good as we're doing it now, so they can consider it. And so the way we've approached that is to try and convince the payers and Medicare of these points I'm making, but then also to get it into the workflow in such a way that it makes sense to them. So I showed you a few reports that, the trend predictions and the gaps and things that are very useful to use. And we are, every day sitting down with somebody to say, take a look at this report, and grabbing them by the lapels and say, you could see this every day if you want, and work it. And so it's a variable success. I'd say we're probably 25% of the way towards adoption I want us to get. And Dick has some experience here too, if you want to weigh in on this one.
Dick, did you want to add anything to that? Thank you, David, for that.
Sure.
I'm muting here. Sorry. I don't have a whole lot to add to that. No, I think it's a bit of a conundrum in our world that we have to have this. It's part of being the trusted, neutral convener, I think, in that sense. So I don't have a whole lot to, not a whole lot of wisdom to add to that one.
So. Thank you. I have a question that came in on the chat specifically, David, for you, and that's if the providers have to pay to use the tool for participation for sending their data in, and if so, if that would obviously potentially be a challenge for the smaller practices.
Yes, they do, but their CPC Plus funds are all eligible to pay for this process. So many of them, we're seeing a somewhat concerning trend among practices in that they're sort of hoarding their CPC Plus funds, anticipating they're going to be subject to the clawback. So we're trying to get them to recognize that nothing ventured, nothing gained here, and that they go ahead and cover the cost of this. They do have meaningful use requirements for interoperability, and making this connectivity helps them to meet that. There are a lot of good reasons, good clinical reasons, if you even set value-based payment models to the side, to be aware that you're prescribing something to a patient that is going to conflict with something else that they've been given from somewhere else. It's just good clinical medicine. So we try to make the case on those grounds. The pricing we set, depending on the kind of organization, at some metric that they we believe they can pay. And of course, as a nonprofit run by these providers and payers, they approve our pricing model. So, the average provider will pay about $60 a month. That's if they're all by themselves, and it gets down to as low as $20 a month if they're a big group. And health systems will pay, I can't remember exactly what, but something per adjusted patient day for their licensing. And then the way we've set it up, that calculates a base fee for the organization, and then most of that base, like 85% of it, is eligible for what we call an analytics credit, so they can buy these quality reports out of that credit.
Great, thank you.
Mm-hmm.
Any other questions or comments for David? David, are you going to be able to share these slides either the way you presented them or some modified version?
Can do that.
Great, thank you. So, for the group, just to remind you, this is being recorded, so we'll have access to the recording just in a few hours after the webinar is over today. And when we have David's slides, I'll also post them up on the website, and this is at the Milbank Memorial Fund Multi-State Collaborative page. Any other questions or comments? Okay, David, I want to thank you so much for this presentation today. And as always, everyone learns a tremendous amount from your experience with MyHealth Access, and from your generous sharing of your expertise. So thanks to everyone, and thanks for dialing in on a midsummer's afternoon. And we'll be in touch. I have one other reminder, which is many of you probably saw an email that came from Caitlin Sedan at the Milbank Memorial Fund today, reminding you if you would like to attend the Multi-State Collaborative annual meeting in Kansas City on 11th and 12th of September, please let Gail, Cambridge, and Caitlin know. We need to be able to do a head count, and if we're able to include additional people beyond the 2 that we normally have from each region, we'd like to do that. So please check your calendars and let us know if you're able to join us. Thanks, everybody. Have a great afternoon. We'll talk to you soon.
Thank you.
Thanks all. Thanks Lisa. Bye-bye.
Thank you, David.
Thank you. Thank you.